how lucky we are to have these two CEOs, good friends. Both came into their current position in 2019. Hard to imagine a more tumultuous 6 years than what they have managed their organizations so successfully through. Kevin and Mr. Mahoney, Dr. Klibanski, both almost their entire careers at their institutions, so they could not be more committed. They're going to have a conversation. This is a new thing for us, no moderator, so you're going to kind of be welcomed into probably an ongoing dialogue that they've had since they got to know each other when they both became CEOs. So I'm looking forward to this session. Thank you both.
Thank you. Thanks, Chris, Michal. So this session really is on the state of care delivery in America, which is a huge topic. You heard from Senator Collins today, you've heard from others on these incredible challenges that we are facing as a nation in healthcare. I think what Kevin and I share, and what so many of you in the room share, is the and the specific challenges that are also facing academic healthcare systems. So it's all of those challenges plus what can we do to best support academic medicine, so fundamental to our identities. So we discussed a number of topics that we might talk to you about and discuss among ourselves. And the first one is really, I'd say it is the role of academic healthcare systems in a very specific thing. It's in cancer care and research. And we selected cancer as sort of the one to pick among the many, and there were so many to pick, simply because, again, it's such an important health, wellness issue, that's obvious, but also because of the incredible innovation that's occurring all the time in that area, as is true with many other areas. But let's start with this one. So Kevin, I know you've done lots of remodeling and rethinking about how you're going to be doing so much, as we all have. And I know you are talking about setting up a freestanding research institute for radiopharmaceuticals. Maybe just start on that and whatever else you'd like to put in there.
No, thank you, Ann. Good morning, good afternoon to everybody. It's a pleasure to be here. You specifically asked about radiopharmaceutics, but let me go back just a step to cancer in general, and I think a new obligation academic medical centers have and why Innovation Forum is so important. So we were blessed to have the first FDA-approved gene therapy. Yep. And the day it got approved, we ran over to the president's office and said, great news. And she said, that's wonderful, what's it cost? And I said, $479,000 a dose. And she said, my God, what did you guys create? And then my good friend Zeke Emanuel from Harvard, now down at Penn, he wrote an editorial, Can We Afford to Cure? I think part of our obligation to innovation is not just to cure cancer, not to come up with new ways, but to come up with cures that the country can afford. So we're leaning in heavy to radiopharmaceuticals. We have an institute that we're standing up, but with precision oncology, how do we eliminate 42 visits to the radiation oncologist? How do we drive that cost down? So we're hoping for industry partners, some of which are in this room, to go in. That's why it's freestanding, because the cost is about $488 million. Yeah. And that's a lot for Penn to take on. So we're trying to put this together, build another ecosystem around radiopharmaceuticals and that precision oncology that the promise is out there.
No, it's really exciting, and I think that you've highlighted what we all face, which is how do you take these two things, which should be working together, which have to be working together, and actually make them one. And that is, how do we advance the innovation? How do we advance the innovation? That's why we're here. That's what we're always thinking about. And all of the components, or so many of the components to advance innovation, they exist. The tools exist. And then there are so many tools that are beginning to exist, and all of those future tools. So all of that is incredibly exciting. And there's a cost to it. There's the investment in it, the investment in the technology, or the methodology, or the science of it, and the people who are doing the work, people who are coming up with those ideas. How do we support those people? So there's all that investment that has to be made, not to mention the physical plant. All of that is an investment. And then there is what does that mean in terms of healthcare delivery? How do we actually take those innovations and then have them create better care, lower cost, all the things we're thinking about? It is also probably a moment to flag that when we are all talking and thinking about innovation in the way we do, innovation in healthcare delivery, whether you're in an academic healthcare system, a non-academic healthcare system, a system which involves 50 hospitals in 10 states, one state, whatever that looks like, what is the innovation that's going on in healthcare delivery that takes all of this incredible science, all the technology, all the things that you're talking about, that we're talking about, and actually change the delivery of care? That's innovation that we keep talking about. That's a challenge we keep talking about and thinking about, but there's a lot that has to be done in that space. So if I think about the kinds of things we're doing here at Mass General Brigham, first of all, I think it is, and I'm now going to try and put together the research, the education, the care delivery model, and all the things we're talking about. We'll talk about this a little later. How do you use community better? How do you bring care closer to home? And I know you're doing that in so many different ways, including cancer. If I think about Mass General Brigham and where we are, setting up the Mass General Brigham Cancer Institute is really the first time in over a quarter of a century, when this healthcare system was put together back then, that we can actually have one system, two great academic hospitals, Mass General and the Brigham, working together with all of the specialty hospitals, community hospitals, outpatients, affiliates, et cetera, to actually deliver cancer in an integrated way. Infused, embedded, informed by research. And that is what we've been talking about doing for a long time. This is the first time right now when we're actually working on that, and that is what we're launching, and that is, I think, going to be really important. First of all, just from an investment point of view, being able to invest in a system of care, to take all the research together, all of that as a single investment as opposed to piecemeal investments. And I think one of the things we all confront in many areas is piecemeal investments. This place wants to do this and this group wants to do that, which is not to take away from the individual or small group innovators. Phenomenal, absolutely important. But how you scale it up, particularly in the current economy and in the current healthcare environment, to scale things up so that we can actually have that single investment. How do we look at, in terms of therapy, future of gene therapy, cell-based therapy? How are we looking at new diagnostics? How are we looking at early diagnostics? All of those things can now be done at scale by launching this institute, which I think is incredibly important. The second thing, and this is obviously related to this forum in particular, is how do we make investments and how do we spin out companies? How do we find those innovators, certainly within our system, and I know you're doing it and so many others are doing it. But again, this is something that Chris Coburn, Roger Kitterman, working on the investment fund, it's really how do you create a venture fund within your own academic healthcare system or non-academic healthcare system to harvest the innovation that's going on all around you, to identify who are those promising investigators. How do you put together the right research teams, sometimes who are working in different parts of the system on similar and complementary things, to actually create something real that can lead to a new therapy. And those are the many, many, many companies that we've spun out here at Mass General Brigham. And I think more and more leaning into that model to create companies, to find all of those ideas that are out there that can be invested in and scaled up and will actually make a difference in human health. So I think just in terms of cancer, looking at these new models, leveraging research, leveraging all of that is really important. And just a final note on the research, most of the research funding in cancer in Massachusetts comes to Mass General Brigham, but it exists in different places. It's at Mass General, again, it's at the Brigham, it could be here. Putting this together as it is, because that's where all those investments are, that's where the NIH money comes, it comes to this system, that is going to be a way of also breaking into the future. So I want to turn to...
And one more
No,
thought
please,
on,
go ahead.
cancer care
Yeah.
that we've been studying is the time toxicity of cancer delivery. So 60, if you have cancer, 60% of your time is spent commuting or in the waiting room.
Yeah.
And how do we eliminate that to reform? That's more patients we can get in if we can shrink that down. So using a lot of digital tools
Yes.
to make sure we get out of the pattern of every 6 weeks you got to come back, get your symptoms checked and the like. But tackling from both sides, heavy innovation,
Yep.
the wet bench, and some lighter touch that makes a difference.
No, I totally agree with you. Sometimes when you actually go around and talk to people and talk to patients, it's that light touch that can have enormous benefits. So I 100% agree with you. Let me move to new care models and a transition from brick and mortar care delivery to reaching patients where they are. So I want to make just 2 comments on that. I'm going to turn it over to you, Kevin. I know that you've done a lot in distributing care into the community, not that you shy away from bricks and mortar investments as well, but I wanted to just start by maybe mentioning 2 things. Number one is when we talk about new care delivery models, sometimes it is taking a care delivery model that started 100 years ago and then bringing it back now. So when we talk about hospital-based models of care, that's in the spectrum of history is actually fairly recent. The concept that care gets brought to an office is new, relatively, in the historical timeline. Care for centuries was delivered in the home. Someone would come to a home, a doctor, somebody would come and do something, deliver a baby, make a diagnosis, give medicine. So this hospital-centric system that we have created, I'm not saying it should go away. Obviously, there's a huge role for these hospitals in providing the kind of complex care they do. But what is an academic hospital? What is a community hospital? And fundamentally, what occurs at home? So I would just talk about 2 things quickly. One is home hospital. Home hospital has been something that we have invested in heavily. We're one of the largest home hospital platforms in the country. And I would say 3 things about home hospital. First of all, it's not new. People are like, this is great, this new thing that's been invented. I think it was at Penn over 25 years ago where articles were being written about providing care at home. So there's nothing new about a lot of these things. It's just never actually been done, hasn't been executed on, it hasn't been proven, and it hasn't been funded. So numerous studies have shown that care in the home, providing hospital-level care for appropriate patients in the home, has better outcomes. People don't fall as much. They don't get hospital-acquired infections. Anyway, my point here is that it's an excellent model of care in the home. And to just go to something you mentioned, it is highly technology-enabled. You really have to have the right technology that patients can use that then can be transmitted working with the appropriate staff. So that's one point. Second quick thing I'll mention is the work with ARPA-H to create the Paradigm program. And you may have seen this in some of the demonstrations that are out there, but this is really creating a new scalable platform to bring medical devices, technologies to rural areas. One thing Senator Collins mentioned today is rural health, and we know there is this fund that's been created. There's $50 billion earmarked for rural health. And how that gets deployed really depends on what the future of rural health is, knowing that there are over 60 million Americans who really are not going to have much access. So I just want to emphasize, tying it back to innovation, that innovation in a space of how we best deliver care to rural communities, knowing that these community hospitals, one by one, are closing. This is an important message for us on how we can use technology, whether it's telestroke or virtual ICUs or all the various things that have been talked about, but it also depends on continued funding for those programs. So I'll turn it over to you, Kevin.
Sure. No, I think there are 2 things that are going on in this space. One, we learned out of COVID that people found out that they didn't have to travel as much, and they got used to staying within about 5 miles of their house. So increasingly, people are looking for care closer to home, and we need to adapt to that. The other thing that I've tried hard to get my colleagues at Penn to adapt is the mantra of there are no unprofitable patients, just unprofitable delivery systems. And the One Big Beautiful Bill Act,
Right.
our reimbursement for Medicaid will go from about 83 cents on the dollar to 56 cents on the dollar. Would I prefer 83? Of course I would, but I'm getting 56. So how do we redo our system so that we can live on 56? And a lot of it is not the old way of coming into bricks and mortar, but how do we, with less cost, but a focus on clinical outcomes and rigorous study to make sure that our digital tele interventions are working. But we're leaning in heavy to meeting the patient where they're at. As you mentioned at home, it takes a lot of discussion with the local payers. We get great inpatient reimbursement.
Yeah.
We don't get such good outpatient and home care reimbursement. And as the world has shifted, we're about 65% ambulatory now in our revenue. Every time we put a patient at home, it is saving the payer. It's costing us and saving the payer. So trying to convince them that they need to incent and increase how we get paid at home, I think is a big part of what our success will be.
Well, I love the way you've highlighted this sort of reverse or perverse incentive system that we all live under, because if you bring people together and talk about what the right models are, they're not that hard. I mean, many of them, as I mentioned before, have been talked about for decades. We've seen what works, we've seen what fails, and everyone is grappling to get to the right model, and it's hard. And this it's the cross-subsidy model within a system that's very hard. Yeah, go ahead.
No, I refer to that cross-subsidy as Jenga. If you ever played Jenga with your kids, you pull the sticks out and they fall down. What I worry is every time we make a change, you're pulling a stick out, and you may pull out the one that collapses the whole thing. So the more we could get away from cross-subsidization and getting paid fairly for what we do, I think would be an important step forward.
No, I totally agree, and it gets to the Medicaid discussions and unreimbursed free care, all of the things that we've talked about. You develop these compensatory mechanisms, as one does in a disease state, but sometimes they kind of get you through, but they're not particularly functional in the end. So I totally agree with you. We mentioned technology, and I just want to maybe jump to a related question. The question of the use of AI in academic healthcare systems, in fact, in all of healthcare delivery, is a huge topic. But maybe just to touch on two things. One is, what have you done in terms of a successful way in terms of improving patient care, provider experience, whatever you choose to talk about?
Well, AI is going to solve everything. Because every time I go and we can't make budget, AI will take care of that. It's
tomorrow.
Tomorrow.
Yeah.
It has such great promise, and as you and I have gone through our career, more and more of the healthcare dollar is spent on administration, not on bedside and patient care. And I think AI first presents a real opportunity for us around pre-authorization, pre-certification and the like, and we're working on that. A challenge that I've floated in Philadelphia that I hope we can get picked up is, rather than Penn developing an AI pre-certification and Mainline Health developing an AI pre-certification, all to talk to Blue Cross and Pittsburgh and everybody, could we take a more utility approach? Could we all agree on one AI solution for pre-authorization? I know that runs against our competitive nature. We want to be the first in Becker's to have an AI tool, but it is an area of cooperation that I think would improve healthcare delivery. We're spending a lot, as you said, on the physician experience.
Yes.
Everybody's chasing the same thing. A bridge is making great progress on ambient listening, managing the email box. What I'm more interested in is how could AI keep a patient on their statin so that they don't end up in the cardiac cath lab. Our physicians want to do right by their patients, and it's just this plethora of activities they have to do that is just killing them. And We made a lot of money in our ACO. You know, I call it checkbox quality, you know, where you go through and if you've done smoking cessation counseling, you get a star. And, but could we do medication adherence? Could we do true normotensive blood pressure monitoring and focus on that? Yeah. And I think AI will play a huge role in that.
No, I agree with that. I think certainly in terms of the ambient technology, physician, nursing, any other notes that need to be done, that's been enormous. I mean, we started with our primary care doctors, and if you've ever not seen a demonstration, either with your own healthcare provider or somewhere else, it's very impressive because the notes that come out, it's really a way, I mean, having spent years taking care of patients and looking at a screen and then trying to look over, to actually not do that, you press a button and you can actually look at a patient the whole time, never look at a screen, and just talk through an exam. I mean, that's phenomenal. And the notes that come out very, very, very fast. It's a matter of seconds, and they look beautiful, and they are intelligent and take very little editing, and people like them. So very different experience from rolling out the electronic medical record for the first time. I think we can all agree on that. So I think in terms of that patient point, did you want to
No,
make
I think a further example of AI, we call it Chart Hero. It's not just the ambient listening. It's, you know, my wife wasn't feeling well. She had pain in her back. She was coughing. I said, you might have pneumonia. We went to our Penn-owned emergency room. She gets swabbed. They say you have the flu. Go see your primary care doctor. She sits down in front of the primary care doctor who has no idea that Pam had been to the emergency room.
Yes.
In the system, it was all inside that record. So in addition to ambient listening, it's also pushing forward relevant information that's in the chart so the doctor doesn't have to hunt and peck for it, or worse, reduplicate it, which is just driving up the cost.
No, I'm glad you mentioned that because the pull and the push and how that comes together is important. In terms of the point you made about competition, I totally agree with you. And what we see now is, I mean, there are a lot of small startups that are actually working on this, and one person will try one or one will try the other. But the big convener in a lot of this is primarily Epic. Yeah. So, you know, these things typically need to be bolted onto Epic. So there is a commonality in platform, although not necessarily in philosophy, that groups can actually leverage. The only other thing I'll say, because we have another thing to talk about in the time remaining, is the importance of AI in terms of diagnostics. And I mean, there's a lot to say about this. I think I'll say that image-based diagnostics, so what we're seeing in radiology and then coming is pathology, is really phenomenal. How that really helps the radiologist, how it can scan numerous films, tell you what scan needs to be done, what are the all of these things will be hugely helpful in diagnosis. It's also very clear that diagnosis that's not image-based is also changing very rapidly in a positive way, but again, you have to be paying attention to the data that's coming in. And a point that was made earlier today is you really do have to try things out in your own population, in your own system, and see what the gold standard of data input is, because otherwise you can be seriously misled. But you know, the points were made earlier today. We're also living in a society where patients come in and they have their diagnosis, and it can be by someone else or it can be by a Google search, but it's usually something on TikTok or something that they've read on X or something that someone told them from somewhere. And that's a hugely dangerous thing. So I do want to move to workforce challenges. Workforce challenges are a huge topic. Maybe even when we're thinking about it in terms of the entirety of the workforce, taking care of patients, doing research, there's a huge challenge in workforce turnover, remote work, competition in other non-healthcare systems. I would also say that since COVID, and I've seen this in so many different systems, the pride that non-professionals would take in working in a hospital, in an organization, which was really huge. People would stay in various positions for so many years, really crashed in favor of remote work. You can make more money working at an Amazon packing company. So that's just one thing to consider. And then when we think about the doctors, the nurses, the researchers, the other professionals who work there, how do you keep and train and retain when the challenges are really hard? I mean, we heard about the challenges for scientists in terms of NIH funding and international students and international doctors. So I would say very specifically thinking about how we best engage people, and also very specifically thinking about pipelines or way to bring in people from other jobs to these jobs, and also potentially create jobs in a community. So I'll turn to you to start.
Yeah, two things. The shortage is real for, we talk about the baby boom and the baby bust. Us boomers are getting older. We're all going to be on Medicare, I think, by 2028. We want to live well and long. So demand is going up.
Yeah.
At the same time, 2008 in the recession, birth rate has dropped dramatically. That was 18 years ago. So the shortage is really hitting us. I think we have to change our model. In healthcare, it's go to school, come with tons of letters after your name, and we'll pay you. Mm-hmm. My son went to the United States Military Academy. They paid him on the first day. They taught him to speak Arabic, jump out of a plane, shoot, like he got paid. So we're calling it earn to learn. How do we change it rather than you rack up debt, you get all, come work at Penn, we'll pay you from day one as you make your way through that process. And we're not gonna, we'll have to figure it out, but we're not gonna get through the workforce shortage simply by increasing rates between us and Mass General, between us and Jefferson, because we'll just bankrupt ourselves. But how do we help people on their career? And again, we call it earn to learn.
I think that's terrific. I mean, we do talk a lot about skill-based learning. That's the other thing, and not assuming proficiency, aptitude, or talent based on degrees alone. I think that's been an important thing to think about. I think in terms of engagement, you can't stress sort of the bilateral communication that has to occur. There's so much distrust and mistrust out there that constant working on communication and engagement at the local level as well as at the system level or the hospital level is really critical, because people really do look to the people right above them to understand what's going on and what its importance is. I will also say that in terms of pipeline, we've done a lot of work with nursing, with high school students. The Bloomberg Foundation gave us an amazing grant to go to one of the high schools right near the Brigham, actually, the Edward P. Kennedy School. You had some incredibly talented kids there who were really looking for career options. And it basically funded them to work in the hospitals, engage in wraparound services, and people could choose careers and get jobs depending on their training or what they wanted to do within our system. And there were so many initiatives with nursing. It's really trying to find people locally. The other thing that is, I think, really important in terms of rural communities, whether you have a hospital, whether you have a freestanding ED, whether you have a medical office building, whatever that looks like, is try and find ways to employ people in the communities. That's just a really important way of gaining traction. And for example, there are jobs like EMTs where you don't need a college degree. You could, but you can get a job in healthcare with delivery, especially in rural areas. And I think that's an important thing to emphasize as well. So last thing I wanted to mention, which is actually one of the most important things, although it gets alluded to all the time, is really, again, supporting research and robust innovation in light of medical cutting of research funding. What will be the NIH of the future? We don't know. And again, it's these significant cuts to Medicaid. Again and again and again, when I think through all of the biggest challenges, it all keeps landing back to Medicaid. So maybe just talk a little bit about how you're thinking about that across your system.
Yeah. No, so a big part of what Penn is doing is we're trying to show our senators that we're also making the investment. So similar to Mass General, we have an investment fund. Mm-hmm. We're spinning out companies. Our donors are putting the money in. So we're trying to stop academic medical centers, are taking the money as opposed to philanthropy's kicking in. We're making the investment. We're pushing forward. We need the federal government to be a partner in moving it forward. And there are a lot of dry wells in research, but there are a lot of fantastic breakthroughs, and we could all go back and tell that. The very last thing we've tried to do is to humanize our story. So we had an incredible work with Children's Hospital of Philadelphia on a young baby with CRISPR technology. When scientists told the story, they talked about a life saved. They talked about the impact on the family and stayed away a little bit from CRISPR, some of the jargon they get. So humanized research, I think, is an important part of our telling the story.
The communications mission shouldn't be as challenging as it is. And, we heard a little bit about, I would say, the linguistic dissonance between trying to explain what an indirect rate is versus that's one part of it. But the other is what you just said, and I think it's really critical, is how do you tell the story so that someone can see a family member or a friend or a colleague in front of them with something that absolutely changed their lives in a bad way, and then in a good way, depending on what happened. So sometimes we're very technology heavy in our discussions, scientifically heavy, in a way that absolutely does not resonate with those people who we should be making partnerships with. And I see we've run out of time, but I just want to say about partnerships. Partnerships you've mentioned with the government, very critical. And coming in as a unified voice. There are partnerships that we say exist, but they don't really exist. So the more partnerships we can have that actually will gain traction with the government, I think is critical. At the state level and obviously at the federal level as well. Partnerships with industry we've discussed many times, and I'll just end by saying I appreciate your partnership over the years. So thank you,
Thank you.
Thank you, everybody.